Hi, my name's Tim and I'm a doctor in acute medicine at the Royal London Hospital and an epidemiologist at the London School of Hygiene and Tropical Medicine. I've put together a series of short talks looking at some of the evidence underlying what we know about the current COVID-19 outbreak. The focus is on the primary research studies that contribute to our knowledge of this new disease with the aim of evaluating how we know what we know. This is a fast evolving field, and I will periodically update these talks when new research evidence becomes available. The references for the papers can be found in the comments underneath the video. This is a basic model of the cycle of an infectious disease that results in spread within a population. Starting from the left of the screen, the diagram shows that within the population, there are people who are susceptible to the infection and those who are immune, either through previous exposure or through immunization. When a susceptible individual is exposed to an infectious microbe, they have a risk of becoming infected. Once infected, there is usually a period of time before they become infectious and can transmit the microbe to another person. The time between being infected and becoming infectious is the latent period. The time between becoming infected and developing symptoms of the disease is the incubation period. And the infectious period is the total time during which an infected person can transmit the infection to a susceptible person. There are a few important caveats to mention before I begin the talk. This is not a systematic review. At the moment, somewhere between 100 and 200 new studies about coronavirus are published every day. This is just my personal review of important papers with a focus on high quality data and study design, highlighting those that may change clinical practice. That being said, I hope you find the focus of the evidence here useful in your daily work. First, I just wanted to have a look at the epidemiological data from different places currently affected by the COVID-19 outbreak. When the contents of a slide refers to a specific country population, I have added the country's flag in the top right-hand corner of the slide. So these are the data from the Chinese Center for Communicable Disease Control, showing the epidemic curve of the outbreak in China to the 11th of February 2020, comprising more than 72,000 cases. The top graph shows the total number of cases, including suspected and those diagnosed clinically. The bottom chart shows just the number of cases confirmed with a laboratory test. The top graph shows a very small number of cases in December, with significant escalation in early January, followed by an explosion in mid-January, which then tails off into February. Overall, this curve is consistent with a highly contagious infection with rapid person-to-person transmission in a highly susceptible population. This is the epidemic curve of more than 24,000 confirmed cases in Italy to the 16th of March. In China, the first cases were related to zoonotic transmission in an animal market, followed by person-to-person spread. However, as this was a new disease and there was not widespread availability of testing nor active surveillance, this meant that this started with a relatively small number of cases initially. The curve for Italy shows the explosive growth of this infection within a fully susceptible population, suggesting a highly transmissible microbe, likely with multiple people spreading the virus into the Italian population at roughly the same time. Although in a different format, this epidemic curve shows the total number of cases and deaths in the UK to the 4th of April 2020, where things are currently at a much earlier point than they are in either Italy or China. The conclusion of these three epidemic curves is that COVID-19 appears to be behaving in a similar way in a variety of populations and contexts around the world. So the first important question to answer when faced with a new infection that has the potential to cause country-level epidemics and global-level pandemics is what factors about the infection contribute to its transmission. There are several important epidemiological measurements to consider that affect the speed and size of an outbreak, as well as inform the control measures required to reduce it. As described earlier, the latent period is the time from infection to becoming infectious to others. The incubation period is the time from infection to becoming symptomatic. The basic reproduction number, or R0, is the number of secondary cases from one primary case in a population with 100% susceptibility. The serial interval is the easiest thing to measure on the face of it, which is the time between cases becoming symptomatic. So one person with symptoms transmits it to another person, and the time before that person also develops symptoms. The transmission dynamics is determined by the frequency of exposure to people who are infectious within the population, and this is often called K. I'm going to move on to cover the evidence for some of the factors that determine the transmission of coronavirus. Of the many factors that affect transmission, I'm going to focus on 4 of them here. There are other important factors, including things like the method of transmission. However, the evidence base for the methods of transmission of respiratory viruses through droplets and aerosols is well known and has not been subject to much additional research as a result of this outbreak. Although, that being said, there is some emerging evidence that this new coronavirus can be shed in diarrhea as well, creating the potential for fecal-oral transmission, although this route is not confirmed. However, I'm going to cover this in a later talk. The first factor I'm going to talk about here is the infectiousness of the virus, which gives a likelihood of the infection being passed from one person to another. This is quantified by the R0, which if below 1 generally results in a reducing number of cases, and if above 1, an increasing number of cases, giving epidemic potential. The higher above 1 it is, the more transmission there is in a population. The second factor is the amount of time someone is infectious and at risk of passing the infection on to others. This is the infectious period, but the incubation period is also important to consider, which is the time between infection and the onset of physical symptoms. This leads to the third factor, which is asymptomatic transmission. This is where there is transmission within the incubation period. The longer someone is infectious during the incubation period, the more difficult it is for an outbreak to be controlled, as identifying people who are transmitting the infection in the absence of symptoms can only be done by testing very large numbers of asymptomatic people. The final factor is population mixing dynamics and how this affects the amount of exposure individuals within a population get to the disease. This is a summary of some of the primary studies and early review articles based on the epidemiological data from the early disease outbreak in China. R0 was relatively well defined early in the outbreak and estimated to between 2.2 and 2.6, with some variation in the precision of this estimate showed by the confidence intervals, ranging from about 1.5 to 4 or 5. Some studies found a higher R0, which were aggregated in the review of 12 studies by Ying Liu in the Journal of Travel Medicine, which pulled the mean up to 3.28. Of note, this was not undertaken using modeling or meta-analytic methods, so it's a very crude estimate, but does show that some studies did make higher estimates. The incubation period was defined relatively early and ranged from 5 to 6 days, but in the review undertaken by Yihuan Wang and colleagues, they identified a large range of incubation periods ranging up to 24 days. An interesting study was undertaken by Fang and colleagues, which is presented in the lower row of this table from Johns Hopkins, which has been released as a pre-publication paper. The study undertook detailed case and contact identification in a defined population in China in order to trace and isolate all contacts. They found the incubation period in their population to be 4.8 days on average, with a serial interval of 6.3 days. What's interesting about it is that with aggressive contact isolation, they calculated their R0 to be 0.4, which would be sufficient to control an epidemic. They also found that within their study population, 80% of the secondary cases came from only 9% of the primary cases, which gave rise to the notion of super spreaders who infect many more people than average. There have been various attempts to put the epidemiological data from China into various mathematical models to try and calculate the R0 and other statistics more accurately for a larger population. In the modeling studies, R0 is generally higher than in the epidemiological studies, as the models can include an estimate of the total number of undiagnosed cases and the amount of asymptomatic transmission within the population, which is important when there is limited testing available. Overall, the lower limits in these studies have been roughly the same as those found in the primary studies, but they often extend higher to 3 or 4. This is due to the amount of uncertainty programmed into the models around specific parameters for which there is currently very little data. Interestingly, the incubation period was estimated to be roughly the same as in the primary studies of around 5 to 6 days. The final study listed in the table was conducted on the explosive number of cases in mid-January in China and shows how high the R0 can be during periods of high transmission, ranging from 5 to 7. This just demonstrates how difficult it can be to predict the behavior of a new infectious disease in a population, particularly when it comes to trying to estimate the number of cases and deaths, as well as identifying appropriate and proportionate control measures to put in place. It's also important to remember that R0 enables comparison between different infectious diseases to give an estimate of their infectiousness and their likelihood of causing an epidemic. However, R0 is always calculated for a population where 100% of people are susceptible, which isn't always true to real life. Here is a modeling study by Prof. Yaking Fang from the School of Public Health in Guangzhou, showing the change in reproduction number over time, modeled from a real population in China. The change is as a result of the control measures put in place by the Chinese government after the 23rd of January, which I will discuss in more detail in a later talk. But it shows an initial escalation from an R0 of 2.4 to 3.2, followed by a gradual decline as these control measures take hold. The reproduction number calculated in a real population is known as the effective reproduction number, or RT. Many factors can affect the effective reproduction number, including population mixing and proportion of people susceptible to the infection. However, the same rule applies to RT as R0. If it can be moved below 1, then the outbreak can be contained. So we have relatively good data estimating the R0 in China based on very large numbers of cases. However, there is a significant reliance on mathematical modeling, which is limited by whatever parameters the modelers choose to put in the model. And one of the areas of greatest uncertainty at the moment is asymptomatic transmission, which is what I'm going to look at next. Several transmission studies have been published that provide detailed evidence for asymptomatic transmission of COVID-19. One of the earliest was this study by Camilla Rothe and her colleagues from Munich in Germany, published in the New England Journal of Medicine. It's a small transmission study of 5 people. At the top, you can see the index patient who was asymptomatic during a visit to Germany, where they attended business meetings with patient 1 and patient 2. They later returned to China, and when they returned to China, developed some symptoms. These were mild symptoms, and later had a positive PCR test for coronavirus. The index patient was asymptomatic at time of contact with patient 1 and patient 2. But both patient 1 and patient 2 later went on to develop symptoms, and then both had positive PCR tests. Similarly, patients 3 and 4 did not have any contact with the index patient, but did have contact with patients 1 and 2 while they were asymptomatic, which is shown by the orange circles with the C in the center, both of whom went to develop symptoms and later have positive PCR tests. Another example is this transmission study from Zhendong Tong from the Zhoushan Center for Disease Control and Prevention, published in Emerging Infectious Diseases. This is a larger transmission study in 2 family groups. The index case is W at the top here. The white boxes show no symptoms and the red boxes symptoms. The blue boxes show potential contacts between people who later was confirmed to have coronavirus disease. So patient W at the top has asymptomatic contact with patient A and patient D, shown by the blue boxes with white boxes above them. Both A and D go on to develop symptoms and get positive PCR later in the course of their disease. Interestingly, A has contact with person B, and person B has a period of asymptomatic and symptomatic transmission and later a positive PCR. However, both E and F have never developed any symptoms, but also have positive PCR, showing that there's possibly a relatively high proportion of people who are infected but asymptomatic. So although these studies are very small, they provide an extremely detailed picture of asymptomatic transmission and good evidence that asymptomatic transmission can occur. So it's important to know what proportion of people have asymptomatic infection and are potentially at risk of transmitting the infection to others. And the best way of doing this is by looking for closed populations where 100% of the people have been tested, whether they have symptoms or not. Fortunately, there have been several examples of this during the outbreak, including the Diamond Princess cruise ship. So the Diamond Princess cruise ship was found to have an outbreak and then later quarantined, keeping all of the crew and passengers on board. There was 3,711 people in total, all of whom were tested. 20% of them, 712, were positive at the time of testing. of which 46.5%, 311 people, had never had any symptoms of the disease, and so theoretically at risk of asymptomatic transmission to other people. There have been some other examples of this, including data on Japanese citizens repatriated from Japan to Wuhan, from Wuhan, who were all quarantined and tested. So this was 565 people, of whom 12 tested positive on return to Japan, and 5 of them had no symptoms, giving a 42% ratio to symptomatic cases. And this gives a rough estimate that the true ratio of symptomatic to asymptomatic is somewhere between 17 and 67. That's the trouble with a small study. So although the precise proportion of people who are asymptomatic remains unknown, these small studies suggest that there are relatively high proportions in the range of around 40%, although with a high level of uncertainty. However, the question remains as to what proportion of total cases result from asymptomatic transmission. Yang Liu and colleagues at LSHTM undertook a probability modeling study using data from Shenzhen in China and estimated that 23% of transmission in this population came from asymptomatic cases. They also estimate that if all symptomatic cases were isolated, and they're relatively easy to isolate, either self-isolate or through control methods, this proportion would rise to 46%, which means that around a third of all secondary cases could be prevented even if asymptomatic cases are not isolated, which shows just how important control can be. I'm not going to spend much time talking about social mixing here, as it's going to feature more in the talk on the effectiveness of control measures. However, this is a nice example of how social mixing patterns affect virus transmission. Christopher Jarvis and his colleagues at LSHTM used the social mixing patterns collected through the Polymod study, which took place before the epidemic, to estimate the impact of social mixing on R0 in the UK. Of the 7,290 people in the Polymod study, they kept a diary of their physical contacts involving skin touching and non-physical interactions with people on a daily basis. The heat map on the left shows the frequency of physical contacts between people of different ages. The lighter the color, the more contacts the people of those ages have with each other. So, for example, the bright yellow box shows that physical contacts between people aged 5 to 17 are very high, with 8 on average, which is the effect of social mixing at schools. And on average, they found about a third of contacts were within the household and 2/3 were outside, either at school or work, for example. Using other estimated parameters, they estimated that R0 prior to any social distancing measures would be around 2.6 in the UK population. So what do these factors mean for the outbreak in the UK? Several researchers have used various combinations of these parameters to estimate the epidemic curve for the UK population. One of the earliest and most detailed modelling studies was undertaken by Jose Lorenzo and colleagues at the University of Oxford. They used the epidemic curve to the 5th of March and a range of possible parameters, including an R0 ranging between 2.25 and 2.75. And they then matched the outputs from various models to the number of early cases in the UK to predict what the epidemic curve would look like. And as a result, they estimate that if the outbreak was not controlled, it would have a duration of 2 to 3 months. At the time of the first death, which was on the 5th of March, around 0.8% of the total population was already infected, somewhere between 400,000 and 500,000 people. By the 19th of March, around a third to 2/5 of the population had already been infected, and that 1% of the population was at risk of severe disease. Arguably, the most influential modelling has been undertaken by Neil Ferguson and his colleagues at Imperial. They undertook a micro-simulation of potential outbreak scenarios for both the UK and the USA. In their model, they estimated R0 to be 2.4, with a range of 2.0 to 2.6. They assumed that 2/3 of people would develop symptoms and be sick enough to self-isolate, which is consistent with a roughly asymptomatic rate of a third, which is based on some of the data that I've shown before. They assumed that there would be a 5-day period between disease onset or symptom onset to hospitalization, that the infection fatality rate of 0.9%, which I'll come to in a different talk, and they assumed that around a third of people who were hospitalized would need some form of critical care during their admission. Of the outcomes that I'm interested in for this talk, they found that 81% of populations both in the UK and the USA would be infected at some point during the course of the outbreak. And if there was no control intervention, the UK would have around 500,000 deaths, and the USA would have 2.2 million deaths. And that peak mortality, shown in the graph on the left, would be at 3 months, which for the UK would be the end of May or the beginning of June. So these are pretty terrifying numbers, but are plausible based on some of the data found in both the primary research and the modeling studies. And so the next talk, I will be looking at the effectiveness of control measures to try and reduce disease circulation and mortality. Thanks very much for listening.